Welcome everybody. Welcome to another installation of DeBakey CV Live, coming to you live from Houston, Texas, from the Texas Medical Center, from Methodist Hospital at the Texas Medical Center, the home of the DeBakey Center, Cardiac and Vascular Center. We're going to have a lot of fun this hour. I have two guests this hour. Our main goal is to help you understand the anatomy of the heart with respect to arrhythmias and specifically atrial fibrillation. This is of paramount importance for the surgeon, but it's really of paramount importance for anyone who wants to do an ablation, because you can't ablate an electrical signal. You have to ablate tissue. And tissue is anatomy. And once we have an understanding of this, I think it will help you understand the differences of different ways to ablate. Now, as many of you know, you can join us, ask a question. I beg you to ask the questions earlier in the show instead of later, so we can try to fit your question in. You have two different ways. They're on the screen now, how to join us. If you're on your computer, go to pollev.com, enter DeBakey, respond to the activity. If you're on your cell phone, you can still join us. You go to 37607, and in the box, text DeBakey. Put DeBakey in the box, and then you can text in your message. So you can join by your computer, and you can join with your cell phone. And we'll show that from time to time. But again, with the cell phone, you go to 37607, text in DeBakey, and text in your question. We try our best to get to every question during the hour. So again, if they come in earlier, better chance that we'll be able to get to your question. Dr. Miranda is the principal of Clinical Anatomy Associates. Dr. Miranda works with research engineers in the medical field from around the country and around the world. He also works with representatives of medical companies. These are the representatives that might come into the operating room and have to have a medical device and show the physician or the surgeon or the cardiologist how to use the device. So he trains the representatives in anatomy as well. He's well known around the world. The last time, I have to laugh because the last time I asked him to join us, I gave him about 20 or 30 minutes notice. This time I gave him a little further notice, but he said, by the way, Randy, I'm going to be in Santiago, Chile during that time. But he said, I'll still do it for you. So Dr. Miranda will join us from Santiago, Chile. It's autumn or fall here. It's springtime in the country of Chile, and Santiago is the capital, and he'll tell you why he's there. He's got a big talk to give on Friday, I believe, of this week in Santiago. Dr. Miranda has been a key player in also helping AtriCure, the company that I work with and that he works with as well, in device development with engineers and also representatives. My other guest is Dr. Junji Morita. He is a thoracic surgeon from Takamatsu, Japan. He happened to be visiting Houston during this time. Dr. Morita is from the Red Cross Hospital in Takamatsu. And the reason that I wanted to introduce him to you, it's a very personal one. As many of you know, Dr. Otsuka is a colleague of mine and spent time with me, and you could say he's a protege of mine, doing the Wolff-Otsuka procedure in Japan, which he has spread around the whole country of Japan. Well, the reason that Dr. Otsuka and I got together was through Dr. Morita. Dr. Morita was friends with the chief of surgery at Tokyo University, which is sort of the Harvard of Japan, and we began a relationship thanks to Dr. Morita, where surgeons would come from that training program to the training program that I was associated with in the United States. And that's how Dr. Otsuka spent a year with me. So before we start with Dr. Miranda, at least I'd like to introduce Dr. Miranda, who's in the studio with me here today. Thanks for joining us, and thanks for setting up this connection, which ultimately has meant that a lot of people suffering from AFib in Japan can have this same treatment.
Yep.
And you mentioned something to me today which I didn't know, hot off the press, right? Tell our listeners about that.
Yeah, today the reason why I'm here is a long story. But anyway, I and Dr. Wolf has been a very long history as a good friend. And during this relationship, we have also Dr. Otsuka is my old friend. And these three are now very eagerly doing the good way to Otsuka and Wolf Otsuka method for atrial fibrillation. And today, a brand new article. In Japanese has published the journal Japan Medical Journal is a very famous article in Japan, and it's a Wolf Otsuka operation is top article.
Top article this month in this journal.
Yeah, 20 pages.
It's published in Japanese.
Yeah.
But this is so not just surgeons or cardiologists.
Yeah,
this is
every doctor.
Every doctor can see it in Japan.
So like this, and this is Otsuka's method precisely. And these 220 pages, it's really wonderful.
Good.
Because this operation is not so popular in Japan still now, but this article makes us very famous. I hope so.
Okay, well, thank you very much. If you have any questions about Japan, Dr. Miranda is here with us this hour. Some questions are coming through, and we're going to get to those. Keep the questions coming. At this point, I'd really like to start the lecture, the meat of the program, and I'm going to turn it over to Dr. Miranda from Clinical Anatomy Associates, who was kind enough to join us from Santiago, Chile. And Efrain, first question is, what time is it in Santiago?
Right now, it's 8 p.m.
So 3-hour time difference.
3-hour time difference.
Okay. And do you mind just giving our listeners just a brief introduction of why you're in Santiago and not back in the States?
Well, I was invited by the Chilean Society of Anatomy, their annual meeting, and I will be giving the closing conference. It's a 45-minute conference on two famous anatomists, medical history, and also some incredible books. And as you know, I love collecting books on medical stuff, so it will be fun.
I would like to ask you then to start your talk about anatomy as it's pertinent to what we're doing with arrhythmia.
All right. Well, give me an instant to start the sharing of this. Oh, there we are. So here we go. Tell me if you see a blue screen.
We do.
Okay. And as soon as I get this going, all right. So the idea was to talk about the anatomical basis of the treatment of AFib, and we're going to go straight into what is known, and this is the classical view of the conduction system of the heart. And in the conduction system of the heart, and believe me, I don't want to give you more information that's needed, but there are two key components of the conduction system. One is called the sinoatrial node, which is the pacemaker, if you will. It's the one that kickstarts this whole mesh, if you will. And the second one is the atrioventricular node. This node is incredibly important as it gives It's the pacemaker for the ventricles. And I know that this requires you to mention the clinical aspects of this. The atrioventricular node is sometimes the last resort in AFib treatment, where the patient is told, look, we've done X number of ablations, we've done so and so treatment, there's nothing else we can do. We have to go in, burn the AV node, and install a pacemaker.
Now, I think, can you hear me, Efrain?
Yeah, perfectly.
I think we should make note that destroying the AV node for arrhythmia, specifically AFib, does not stop the AFib. It just decreases the signals that are going to the ventricles so it can control the heart rate, but it does not stop the AFib.
Oh, that's a very good point.
Yeah.
Well, the main point here is that what is taught in medical school is that the conduction system of the heart, the activity of this conduction system, is what you read as an EKG, an electrocardiogram. But it must be understood, and this is absolutely critical, that all these beautiful little yellow dots and lines, they are not nerves. Let me have that sink in there again. These are not nerves. The conduction system of the heart is actually cardiac muscle cells, which are automatic. They have automaticity. And you can see here a cardiac muscle cell that's beating at its own rate. So this is really, really important. Now, what I propose, and what is actually not me, but is being proposed, is a conduction system in the heart is truly a binary system. What we already saw, the cardiac muscle cell-based system, cardiomyocytes, which is automatic. But then there's a second component, the autonomic nervous system. Now, these are nerves, which act as a modulator. So we have something that beats on its own, and then we have another system that's kind of telling it to accelerate or not. The autonomic nervous system, and before we go there, we need to do a little bit of definitions, because we talk about extrinsic, which means away from or external, and intrinsic. So the autonomic nervous system has a component which is an activator, fight or flight. And it has a parasympathetic component, which is, say, depressor. So what? Well, the simple thing here is that one increases heart rate, the other one decreases the heart rate. These components work on the automatic portion. So you have, it doesn't matter, this is quite complicated, I'm not going to go into the detail. You have these two systems fighting over control of the heart, one accelerating, one depressing it. And this is the extrinsic cardiac system. I have made a point to add here all the clinical papers that this lecture is based upon. See, the extrinsic cardiac system is very complicated. And when we talk about the intrinsic cardiac autonomic nervous system, you've heard Dr. Wolf, you've heard me, you've seen anyone who reads will find talk about ganglionated plexuses. What are these things? Well, the word ganglion is a group of nerve cell bodies. And a plexus, the word plexus means meshwork. So ganglionated plexuses mean an interconnected mesh of neurons and nerves. We call them ganglionated plexuses. Others call it ganglionated plexi. And for our purpose, we just call them GPs. GPs are intrinsic. It's an intrinsic cardiac nerve system. Now, is this a new concept? This is quite new. No. This was first postulated by Robert Bremack in 1838. So this is an old concept. And let me take you a little bit through the history. In 1926, look at this. This here, let me highlight. This here is a ganglion, and you see the little meshwork. But these are sketches. The researchers would look through a microscope and draw what they saw. This is 1996. This is a photograph of a slide. And for those who say that GPs do not exist, here it is.
So he drew those around the time of the American Civil War, and he pretty much got it right, didn't he?
Yep.
Wow.
And this is 1997, and you see how the technology gets better and better. And this is in the year 2000. This is an actual human heart. And look at that. You can see individual neurons. You can see them right there with axons, with nerves. And you see how there are some choke points. And this is what we would like to ablate.
Is that on the outside of the heart?
Yes. And that's absolutely, this is a picture from the outside of the heart. And thanks, because we're going to go deeper into that particular concept. Now, look at this, 2020. Remember the sketch from 19, whatever, right? Look at this. This is in the heart of a mouse. And where you see in yellow, those are GPs. And the technology is getting to a point where we can look at it three-dimensionally. We know where they are. We know where are the clusters. Look at that. It's just absolutely incredible. There are the GPs. And when we look at it, here's the aorta. It's just fantastic. Again, you see it right there. This is brand new. So the main question here is, are GPs found only in the heart? And this is a question that has really guided me in my research. Because, yeah, we know they're in the heart, but they are also found in organs that have rhythmic activity, like the heart, or they have movement or peristalsis, like the intestines, the stomach. If you do any light research, you'll start here, I don't like this term, they will talk about the brain of the intestines, the brain of the digestive system. What it means is that these structures work on their own. They have their own almost internal intrinsic system. That's why, and I think you, Dr. Wolf, you can illustrate more on this. That's why the heart that is explanted and taking and put it as a transplant beats on its own.
Mm-hmm. Yeah.
So this is really, really, really interesting. GPs are found in many places. In fact, this researcher, John Randall Armour, and again, I don't like the term, but he talks about the brain of the heart. It's almost truly as if the heart had its own internal system, the modulator. And he's done incredible research at the Heart Math Institute. And look at the following images. How they have studied the GPs. Now we can see the GPs in detail. Look at this image. The cardiac ganglion. Each one of these is a individual neuron with its nuclei. Here's a cross-section of a cardiac ganglia. So the GPs are really, really important. Now, this work is from Gross and also Armour, sorry. And where are the GPs in the heart? Well, we know that, first of all, they are in these yellow-colored areas, and this is where there is fat. It is also areas that are devoid of pericardium. And they're found in clusters. And they're found, look how the clusters are found around the pulmonary veins. This is, I just want to mention this. There is a huge number of ganglia, of accumulations in the heart, atrial and ventricular.
What's the number there, Efrain?
Yep. Can you see it?
It's small. What's the number? How many?
The number of atria in the the GPs in the atrium is 458 plus minus 43.
Okay.
While the ganglia in the ventricles are about 88, so way less. So the atrium has a lot of. There are the numbers.
Okay.
So, and these go from atria to ventricle. So what's the idea? If you're going to ablate, you need to interrupt these pathways. And I'll show you how the this procedure, the mini-maze, does this. Now, this is probably one of the really important concepts. We know that GPs are in the heart. We know that they are around the veins. We know they're in the areas that contain fat. But they're found, and let me say it in difficult, they're found in the epicardial fat or epicardial half of the atrial wall. They're superficial. So what does that mean?
The outside, not the inside.
Correct. They're on the outside. And it's not me talking. It is all these papers, and there's way more that say this. Just again, this is a type of ganglia. Look at the quantity on the outside of the heart, look at the quantity on the inside. Now, let's put this in perspective. And I just did this. This is a section of the heart. Here is the inside. It's deep, internal, inside. And out here, that's external, outside, or superficial. Where are the GPs? Well, 80% of them are here on the outside. 20% are here on the inside. So when you're doing an ablation, you're ablating from the inside out. And if you test that ablated area, since it's scarred, it has no water, you say, well, we're done.
Isolated.
But look, they're isolated, but look at this. Those are okay, thank you very much.
But they've missed 80%. That's what you're saying. From an endocardial approach.
Correct. So the true way, the best way to do it is go transmural, go from completely from the inside to the outside. This is the way to do it. And this is what a clamp does. I don't know if you want to add something else, because this is probably the most important portion of this.
Well, that's a beautiful drawing. I've never seen that before. And it explains very simply that if you're not on the outside of the heart, you're probably going to miss 80%, or if you're not all the way through. And it's very difficult to burn all the way through the muscle, and you have to be very careful from the inside, because if you burn too much, you'll burn all the way through and have a hole. The beautiful thing about the clamp is that it's bipolar technology. That's what I use. That's what I developed with AtriCure. That's what Dr. Otsuka uses. The clamp, since it's bipolar, only has the energy going from the outside, the epicardium, to the endocardium. And if you check the temperature of the tissue a millimeter away from the clamp, the temperature is normal. So it's an extremely safe way to make a transmural line through the heart. Nobody else has come up with anything close that is as safe, effective, and very speedy. It only takes about 7 or 8 seconds to make that line that you're showing right there. So I do think you very nicely, a simple way, showed maybe why it's difficult to get a permanent solution from an endocardial or inside the heart approach, and it's much easier to get a good solution if you believe in the GPs from the outside in transmural lesion. Back to, let me just, we got some questions and we'd like to get some more questions, so you can, again, let's show that just real quickly. So you've been talking for a while. We better show the how to join to ask a question again. You can go to your computer, pollev.com, enter DeBakey. If you're on your cell phone, go to 37607, and in the text box, type in DeBakey, and then text us your question, and we'll add it to the list here. Efrain, back to you. Must be something in the southern hemisphere. While he's getting back in, let me answer a couple questions. Number one, have you been able to do the Wolf mini maze on a patient that was a smoker for many years? Yes, that's no problem. Dr. Wolf, I've had AFib on and off for the last several months. I've watched many of your presentations. It's a nerve problem, not a heart muscle problem. I have neck and back problems. When I have AFib, I have upper back pain. Do you have any experience with AFib being caused possibly by nerve problems in somebody's back and neck? I'm waiting for a virtual consult with you. Thank you. Well, that's an interesting point. There could be some confluence there. What Dr. Miranda's big picture point is that your heart would be happy to just beat 60 times a minute, but it gets all these other inputs. When you're, as I mentioned, if you're standing on top of a tall building and look over the edge, it scares you. Well, that makes those signals go from your brain through your spine to your heart and tells your pacemaker to go faster. If you just had a big meal and you lie down, there are other nerves, the parasympathetic nerves, say slow the heart rate down, let's digest this food and take a break. So as Dr. Miranda mentioned, there's this interaction of the sympathetic and the parasympathetic. And could it also be from irritation of the spine directly? It could be. It's plausible, I think. One more question, and we're going to get back to Dr. Miranda. I see he's back on there. Is there an advantage to substernal approach to the outside back of the heart as the hybrid maze? Good point. The hybrid maze is where a catheter ablation is performed. That's part one. And part two could be before or after. A surgical procedure is done going up underneath the breastbone and essentially burning the back of the heart, the back of the left atrium. Burning the back of the left atrium is probably not necessary. If you believe what we're talking about, if you believe what the anatomy shows us, you really need to get to the ganglionic plexi. So if you burn the whole back, you'll get some of those plexi, but you won't get them all. And the catheter ablation probably won't get them all. So you're still left with a burden of these nerves that are initiating and continuing the AFib. I'm not a fan of the procedure for that reason. It depends on catheter ablation. I think that's an issue. And two, I think it burns up a lot of the heart that doesn't need to be burned up. It's like carpet bombing the back of the heart when really you should be selective and go for the nerves. That's my opinion. There are other opinions, and I recommend you go on the internet and see the other opinions. I have my third ablation, scheduled for a week. Persistent AFib. Last one lasted 4 years, but I gained weight and let my blood pressure go. And I'm not sure what you want to ask me. But certainly the most I've done is a patient with 7 ablations, and they were told they could never get back in rhythm again. They went back in rhythm during the mini-maze procedure. Let's see, let's take another quick one. The Wolf mini-maze procedure runs for about 2.5 hours, is that correct? Well, it takes me about 45 minutes to an hour to do each side. For people waiting out in the waiting room, your loved ones, it's longer because you have to go to sleep, we do an echo, and you have to wake up. So that takes it to about 2.5 to 3, but the actual procedure is 45 minutes to an hour on each side. Now this is interesting, and I'm going to include everybody on this one, including Dr. Miranda. I prepared some questions thinking they might be appropriate to the lecture. Ablation question. If I'm understanding correctly, GP ablation creates a barrier that nerve signals can't cross and prevents an inappropriate or confused response from the atrial muscle tissue. Do we have any idea as to whether it's the nerve impulses that are dysregulated, or is it the response of the cells of the heart muscle that result in AFib, or maybe a bit both? What anatomy, neural pathway, pickups after GP ablation to make sure that the individual can still respond, fight or flight, to danger or calm down as needed? I'll put in my 2 cents worth in, and I'd like Dr. Miranda to comment. Well, Dr. Miranda pointed out there are many GPs on the heart. We're not knocking them all out. Clinically, what I hear from people who maybe are cyclists or runners is that after the mini-maze, their heart rate variability goes down. It stays pretty steady. So when they exercise, I ask them to exercise, increase their activity slowly. Don't just start off at a run. And they'll increase their heart rate to 100, and then usually by 6 months to a year, 150, and then within 5 minutes come back down. So that response returns. That fight or flight response returns. But right after the procedure, you may have a decreased heart rate variability. That's good. That means we got what we came for. Dr. Miranda, can you comment on that question?
Well, the main thing here is that we're probably not getting 100% of the GPs. Remember, there's tremendous variability. So really, we're getting most of them. And there are rare cases where a Wolf mini-maze or a procedure, the person still has a little bit of AFib. And I would say that's why. You are getting the nerves. That's what you're working on. Because the mini-maze really does nothing for the basic conduction system of the heart.
Now, the question also suggested or asked, is it because we're damaging these little nerves, or is it the response? What you told me was these nerves don't regrow. And could you explain that to our audience?
Well, here's the thing. Could you put out this image, the image that's on the screen? Here, if you look at this, if you were to freeze or damage this nerve, since the cell is still viable, this will regrow. But when you're doing the GP ablation, when you're doing the mini-maze, you're getting not only the communicators, the meshwork, but you're getting the actual neurons. These, when they're ablated, they do not regrow.
Okay, thank you. That's very helpful. I think you should carry on and Because I know you got a few more slides.
Yeah, quite a few, actually.
Okay.
No. So we go back here. So this is where we were rudely interrupted by actually an earthquake.
Really?
Oh yeah, it's Santiago. We had a 6.5 yesterday. No one wakes up for that.
Well,
But,
Dr.
so
Miranda can sympathize with you on that.
So here's the going back to where the GPs are, and this is, I think we should tag team on this one. These are the ablation lines that are done in a Wolf mini maze, and this would be the first one that goes around the right veins, pulmonary veins. Then you do a second one, which have a special name for it. I don't exactly remember, but it kind of gets the larger fat pad on the right side.
Well, I changed the name because you told me to. I call it now the sulcus terminalis line.
Yes, that's we had that discussion.
Yeah.
Then, and you see look how all the GPs, how many are getting there. Then you have this third one, the fourth one, and the last thing that you do is you take out the left atrial appendage. Yep. And I know that you test for these GPs, and sometimes there could be one here. I think you call it 9, or I don't remember.
Yeah, I have to approach with the pen separately.
Correct.
And it makes so much sense, because I noticed that after I placed the clamp, like you've so beautifully illustrated here, all the GPs no longer are active except level 9, and it's exactly where you point there. It's just outside that green line, and I take the pen and stick it under the heart to get that 9. It makes, based on the anatomy, it makes perfect sense.
What's interesting, and let me go back to this image, which shows the communicators, or the communications between the atrial GPs and the ventricular GPs. Look what happens when we add the lines. Most of them are interrupted.
Yeah. Yeah.
So we don't have to go, you don't have to go for the ventricular GPs, because they're incommunicado. Mm-hmm. And that's all I have regarding the rest I have is regarding the left atrial appendage. I don't know if you want to take a minute for a couple more questions.
Let's take a couple more questions. Please ask the presenter to show where the ganglionic plexi are located in the back and the vagal nerve relationships to AFib. I think you sort of did, but maybe you can emphasize that. Yep. They're located on the back side of the heart. This is not the front side, because the pulmonary veins are on the back side of the heart. Here. They're in the fat pads.
Yeah.
And these have multiple interrelations with the vagus nerve and the sympathetic chain.
I should go back. Why don't you take a couple of other questions? I'll go back and prepare the answer for that.
The procedure, this could be the mini maze, includes 2 ports and a 5-centimeter incision on both right and left sides on the patient. Located under the armpits between the ribs. Is that correct? It is. Usually the 4th intercostal space on each side. And if you can show me here, it's about here and it's about here. Post-op recovery is about 3 nights and follow-up in 7 days, and then you can fly back home. Did I get that right? You did get it right. I've had patients go home the next day, but the average is 2 or 3 days. It sort of depends on what the rhythm was when you came in, and how long you've had AFib and how many ablations you've had. But yeah, that's pretty much it. And interestingly, even though it's a heart procedure, a heart surgery, my patients do not generally go to the intensive care unit. They go to the recovery room, and then they go to the floor. So it gives you an idea. And the patients are awake at the end of the procedure in the operating room. Are you doing any AFib research involving patient blood draws to see if there's a genetic link to AFib? Well, we are saving biopsies that we hopefully, and freezing them, that hopefully we can look at in the future. The current research that has been approved here at Methodist surrounds looking at the links, the device I implant, and correlating the type of AFib with the procedure and the link to see what % of patients are staying in rhythm and how much we decrease the AFib burden. Let's see. Blood pressure since my Wolf Mini Maze is, I guess, is better. Thanks, and look forward to my 1-year anniversary next month. Is the LAA isolated at the beginning of the procedure, at the end? If at the end of the procedure, wouldn't any contribution to LA had to AFib signal be missed to be noted? I usually do the appendage at the end. However, if the patient has a history of a stroke, I may do the appendage at the beginning. It doesn't interfere with the testing on either side because the testing is, it doesn't matter what, it just doesn't matter. Let's see. I have a pacemaker. Can you insert a link monitor loop recorder following a mini maze? Well, the advantage of putting the link in is then I can monitor your EKG every day. With the pacemaker, we get a readout every month. Sometimes it just depends on what you want. It also depends on whether the insurance company allows for both to be placed. We don't have to put a link in if there's a pacemaker. It's more convenient for you and for us here at Methodist to watch your rhythm, but you don't have to have both. If the LAA is the source of arrhythmia, why not start there first? Well, most of the time it's not, but in some patients it is because it can act as part of this loop of a macro reentrant circuit of the AFib going round and round. Let's see. How soon do you get blood pressure relief after surgery? It's immediate. I mean, you wake up and your blood pressure is lower, and we usually cut the blood pressure medicine in half, if not stop it altogether. But generally, it's right away. Let's see. Mr. Producer, am I missing any? Or are we caught up with some of them? What percentage of patients that receive the Wolf Mini Maze procedure develop a flutter? Well, it depends. It depends on if the patients had prior ablations, how nasty those ablations were, how much scarring there is there scar outside the area of the mini maze. It can happen. Some of the patients come to us with atrial flutter after ablation. That's one of the most common complications, if you will, or side effect of an ablation is left atrial flutter. We never saw left atrial flutter much at all until catheter ablations. It used to be all right atrial or typical flutter. Now we see left atrial or atypical flutter mainly after ablations. If a patient's had multiple ablations and is already suffering from atypical flutter, there can still be some afterwards. We have a good solution for that. We've never had to redo a mini maze, but we have gone back at 6 months on the EP side to find some rogue signal that's outside the mini maze area. Is there a correlation between Wolf Mini Maze procedure and PVCs? Not that I'm aware of. There may be, but I don't know that there is. PVCs means it's coming from the lower chambers, the ventricular chambers, whereas the mini maze and the AFib is concentrated on treating the upper chambers. Should I go ahead with an ablation next week if I'm over a year away from mini maze? Good question. I would postpone it a little bit. I wouldn't cancel the ablation. I would postpone it and give yourself time to complete your research. Do a virtual visit with me or whoever you plan on talking it over with. So you could still have that still can be performed after you've completed all your homework and then decide what you want to do. But it definitely makes my job a little bit more difficult if there's already been an ablation. And by the way, now there's a marked increase in pulmonary hypertension after multiple ablations. Let's get back to Dr. Miranda, because I also asked him, maybe it was a little too much, I asked him to include a little bit of information about the left atrial appendage, because that's an integral part of treating AFib.
I try to make it very, very short. But to answer the first question, there are some companies, and there's some research being done on putting vagal stimulators to treat AFib. Just remember that treating AFib, working on the vagus only, you're only treating the parasympathetic, the slowed down portion of the nervous system. Others, the sympathetic, the question also includes the sympathetic chain. These are almost microscopic nerves. It's very difficult to find them. So the best way to really get sympathetic and parasympathetic is work on the GPs.
And you might have said it before, but my understanding is, at least on the GPs of the heart, 80% of these are already mixed sympathetic and parasympathetic innervations.
Correct. That is absolutely correct.
Yeah. Okay.
So I'm just going back, and what I wanted to say about the left atrial appendage, and you can the producer may just tell me whenever we need to stop this. Most of what I'm going to say is already in another video that was done on May 5th, 2020.
This is the one where I gave you 20 or 30 minutes notice.
Correct. So basically, the point is that the atrium that we have today kind of pushes out. So the primary atrium moves out and becomes almost like a little ear. And that's why in some countries they're called auricles. For example, here in South America, they do not say atrial appendage. They say auricle or little ear. And that would be the left side. So let's skip the wording, but basically we need to understand that there is an opening, the ostium, that there's a smooth portion in the atrium, and there is a portion that is either trabeculated, meaning mesh-like, or pectinated. Let me show you what that means. That is trabeculated. Now the question is, if you have small, slow flow of blood over this meshwork of muscle, you'll have clots. And that is the structure of the left atrial appendage. On the other hand, the right atrial appendage, right there, look at the direction, look at the smooth that is. So the right atrial appendage does not produce clot, even during atrial fibrillation. On top of that, the left atrial appendage has these little outcroppings that look like the crenellations of a fort. So look at this. It has a small ostium. It looks like a long tube. It has lobes, S's. These we're setting the left atrial appendage. If there's slow flow, the anatomy itself is causing it to create clots, and the term is thrombus. And when this thrombi gets shot out of the atrium, or the atrial appendage into the atrium, they can go into the bloodstream and get to the brain and cause a stroke. Look at the difference between the right atrial appendage, smooth, no crenellations, the ostium is that big. So if you have stagnant blood, the blood will slowly course and come out, not generating clots. But look at this. I mean, the blood will have to go like this, like that, like here, and it's a clot-making factory. And the ostium, which you see here, and here you see a device that's being placed in the ostium is really not circular. It's oval. Where if we place plugs in here, circular plugs, we're distorting the anatomy of the ostium. So, and as I said, I've gone through this very fast because it is, if you want to go back, the video is in the DeBakey library. It is also, there's a link at the Wolf Mini-Maze site. The left atrial appendage is part of the AFib problem, but for two reasons. Number one, it could be electrically active as a focus of AFib, but it's also because of its anatomy. It is, as I said, a clot-producing factory. It has a small ostium tubular. You can read that. So the left atrial appendage, if needs to be excised or clipped when AFib is present. And I wonder, and by the way, I'm not saying that it should be done, but I don't know if you remember years and years ago when the surgeon would go in and to do something in the abdomen and see the appendix and take it out. I don't know. That's a thought. So that's all I have. I think we are doing great in time. Is there any other questions?
First of all, thank you for a great talk. I think it sheds a lot of light on the difference between outside in, or one of my patients said you should call it direct ablation versus inside out on the heart, which they said is indirect ablation. Is it for one, if people have more questions for you, they can reach you through your website. Let's put that slide back up there for a second because it has Dr. Miranda's website. And there's a connection between the Wolf Mini-Maze website and your website as well, right?
Correct. There are links.
So you can go to wolfminimaze.com, and get this information and get a link to Dr. Miranda's website. You can also go directly to his website for anatomy questions, and he does a lot of interesting things on there. It's about history of anatomy, history of surgery, and some really, you can really become educated about some areas you may not know much about. And I don't see it coming up, so give us the website name again.
It's clinicalanatomy.com.
Clinicalanatomy.com.
Correct.
It's a combination of anatomy, history, and all types of little quirky, interesting factoids, I think.
Yeah.
If you're interested in a virtual visit here at DeBakey, you can set that up by going to wolfminimaze.com, WOLFW, Mini and Maze, MINIMAZE. It's not really a mini maze. That was a name that was branded by one of my patients, and it sort of stuck, so that's where we are. I think really what it is, and I've always dictated this in my operative notes, Efrain, I say it's a partial cardiac denervation. It's not a complete cardiac denervation. It's a partial cardiac denervation. I think that's still appropriate. I want to thank Dr. Miranda for being with us and giving us an update on this interesting article that was just published today by Dr. Otsuka on the WO procedure. That's great news. I want to thank everybody out there for your questions. And do we have another question? No, we're okay. All right, we're up pretty good on that. We will reconvene again next month, first Tuesday of the month, 5 p.m. Central Time. Here at DeBakey, I want to thank Dr. Lumsden for setting up these CV Lives. They're very informative. And pretty much as soon as we're finished with this, the producers work very hard to get this up and running. And the listeners can then review this on a couple different sites, right? And Tyree, give me the best site for them to go to, you think? YouTube. YouTube, go to YouTube and look for DeBakey CV Live. DeBakey CV Live. And you can watch this and it'll be up and as long as we're around, I imagine. It's up. Producer Tyree says it's already up now. That's great. I want to thank everybody for joining us. Efrain, I hope you have a great lecture. People don't know this, but in this meeting that Efrain is speaking, usually the presenter is given 10 minutes to give a talk. He's giving a very featured talk, a 45-minute talk, which is great. It's a real honor. I hope you get to enjoy it. And I hope there are no more tremors between now and your talk.
All right, thank you very much.
Thanks for helping us out.
Thank you very much.
Dr. Miranda, thank you.
Yeah, thank you.
Everybody, we'll see you in a month on Tuesday.